I would love to have Shishir talk us about kind of the almost bread and butter and the most impactful use of ultrasound of the brain in pediatrics, which is sickle cell disease. Shishir, the floor is yours.
Thanks, everybody. So I'm going to get going so we can stay on track with time. And these are my disclosures. In terms of describing the current state of the art, let me just re-window here so I can see better. Okay, so in terms of discussing the current state of the art of sickle cell and stroke pathophysiology, we know that stroke, sickle cell, and cognitive morbidity are, stroke, silent cerebral ischemia, and cognitive morbidity are very common sequelae of sickle cell. In 39% of children by the age of 18, silent stroke can occur. And one of the distinguished differences in pediatric ultrasound is that in sickle cell patients, they suffer from this large artery vasculopathy, and they also can have silent strokes. They also can have other mechanisms like hemolysis, hypercoagulable changes, sickling of the RBCs, and changes in vasomotor tone, all of which can impact their stroke care. The cooperative study for sickle cell disease cohort that was conducted in the 70s and 80s looked at over 3,000 children and adults and showed that over the course of time, the proportion that don't suffer from a stroke dramatically decreases. So you can see that even during the pediatric ages, many children are suffering from CVA. There's multiple clinical applications of TCD in sickle cell. There's the bread and butter, as Dr. Sarwal kind of mentioned, of annual TCD screening that we use based on clinical trials that I'll be going over. But, things that I want to kind of stir in terms of your thinking is using TCD as an increased frequency in higher risk patients, considering monitoring intracranial vasculopathy, vasomotor reactivity, and moya as a secondary sickle cell issue. And so, there are applications outside of that, I believe, that we need to study further. So this is a clinical case that I'll just kind of start with to get everybody's juices flowing. And this was just a few years ago in a kiddo who came in and had elevated TAM velocity on their right MCA, came back in a month later, had an abnormal velocity, and then on the repeat TCD had another abnormal velocity and started on chronic transfusion therapy. So we'll talk about how this kind of protocol was developed and why we went about it in this way. This is the MRA of the same patient, so that was a right MCA, and you can see that there's definite changes in the terminal ICA and proximal MCA of the same artery there. On the same MRI, we found silent strokes, very abnormal in a child, and we saw that there were flare hyperintense vessels on the right MCA distribution, kind of showing that there was increased collateral formation, and an angiogram was done and showed this very significant moya-like narrowing, as well as this puff of smoke that we always hear about. TCD can also be used to monitor for low flow velocities, different dampened waveforms, turbulence, harmonic murmurs, all sorts of things that have been described in the literature. And an example, brief example of another case was where we saw exactly that finding, where the velocity went from 140s and dropped off dramatically and led us to draw some question marks. We contacted the provider, we conducted follow-up imaging and found that the patient had severe critical stenosis that was, not known. And so started on transfusion therapy and, hopefully helping them prevent from having future strokes. So what is this based on? Multiple people had been working on this since the early 80s, 90s, and basically the group in the early 90s looked at conducting sickle cell TCD protocol and what we kind of now know as a stop protocol. So taking multiple measurements along the MCA as well as individual measurements on ACA, PCA, basilar, using both transtemporal and suboccipital approaches. And what they found is that people who had high-risk TCD features and high-risk ultrasound findings did have lower hemoglobin, higher hemoglobin S percentage, and higher rates of stroke. They use what we call the TAM velocity, which is where you place the spectral line. You take the spectral outline and then you put the TAM line in a way where the area under the curve X and the area above the curve Y are equal. And what they found was a TAM velocity of greater than 170 was really considered positive. And when patients had that, essentially 7 of those patients who had that threshold had a stroke. 6 out of the 7 had this exact greater than 170 cutoff, but even the one that didn't have that had an occluded left ICA. So you can imagine that probably their velocity would have been higher. Additional studies looked at what kind of threshold of hemoglobin S percentage led to higher rates of strokes. And what they found is that in patients who were getting chronic transfusion therapy in sickle cell, 5 out of 6 occurred in the strokes occurred in hemoglobin S percentage greater than 30%. So you can see in the time to second stroke on the right that the probability of recurrence was dramatically higher in patients who did not get transfusion. And this hemoglobin S percentage cutoff is something that we still use to this day. Follow-up studies done by the same group that then developed the STOP trial looked at their cohort of patients who had long-term sickle cell long-term stroke risk in patients with sickle cell and TCDs, and they found that very similar to their initial trial findings, you can see highlighted at the bottom of the figure that 170 centimeters per second seemed to be the cutoff. And in the Kaplan survival analysis, that was protective if you were below 170, but above that, dramatic increase in the probability of remain or decrease in remaining stroke free, and then if you were over 200, even worse, dramatic decrease in remaining stroke free. So STOP trial was conducted in 1998 and basically took this same TCD protocol and found that if you had 2 times TCD findings of greater than 200 centimeters per second on non-imaging TCD, they randomized to standard of care versus transfusion. Those who got transfusion only had 1 stroke, but the non-transfusion limb had 11 CVAs. And so there was a 92% difference. They stopped the trial early and developed the protocols that we still use to this day. Because this is a pediatric ultrasound discussion, other considerations are that kids are different and TCD is different in kids. So arterial depths are going to be different depending on the skull size. They actually use the same measurement device that your eye doctor uses to measure the head circumference as well as to calculate the midline where ACA and MCA bifurcation might occur. And over time, the head size grows and the depths are going to change. They also increase the sample volume to allow for more confidence in their site of incination. They set their velocity thresholds a lot higher as well in these trials because the kids are purported to be higher velocities first of all than adults, but then definitely more so in sickle cell due to the viscosity being decreased and anemia. There's multiple things that can impact pediatric TCD as well. So crying child, hyperventilation, breath holding, having a fever, being acutely sick, all of these things can affect your TCD. So something to take into mind. And then, of course, the ophthalmic artery is not part of the stroke protocol, even though we use that in adult TCD most of the time and doing a lot of our TCD studies. In addition to this, beyond finding hyper or elevated velocities in TCD, we also look for very low velocities. And we need to think about why a person who's non-transfused sickle cell who has a low hemoglobin might have a low velocity. That's pretty much an indicator that they might have a severe stenosis. Follow-up studies looked at TCDI when that was developed, and they actually studied patients using both techniques and the stop scanning protocol and found that TCDI consistently underestimates the TAM velocity, so we need different thresholds. Guidelines were created in 2020. ASH released these guidelines to help guide us all in terms of how to care for our sickle cell patients, and definitely for cerebrovascular disease and TCD screening. I highly recommend everybody go and read that publication. It's super useful, and go through the recommendations on the cerebrovascular disease section. You can see here that they recommend annual TCD screening for anyone from age 2 to 16 years of age. And if you have abnormal TCD velocities and live in a high income setting enough to receive regular transfusion, that's what they recommended in order to maintain a hemoglobin S percentage less than 30% and a hemoglobin greater than 9. And they recommend regular blood transfusion for at least a year when you find this abnormal finding. In terms of kind of follow up, the TCD findings that you'll be looking for are imaging TCD showing you greater than 185, 2 times measurements of that in the TAMX, or a 1-time measurement greater than 205. In the non-imaging based TCD, you're looking for greater than 200 times 2, or a 1-time measurement greater than 220. So, you guys can take a look at this in the recording later. So what do we do after we start transfusion? Well, they studied that as well. And what they found is that in patients who halted transfusion, high-risk Doppler features occurred and stroke occurred. And in the patients who didn't stop transfusion as a follow-up to the STOP trial, none of them had these high-risk features or stroke. The switch trial was developed to try and see, okay, well, if we take those patients and essentially we look at, hydroxyurea, will that help us? And using phlebotomy, and what they found was that 7 strokes occurred in that hydroxyurea and phlebotomy group, but 0 strokes occurred in the transfusion group. They also found that in the interim analysis, the liver iron concentrations did not really have a dramatic difference. So that really didn't meet safety, and they had to close the study early. The Twitch trial was done not too long ago and looked at hydroxycarbamide and looked at assigning patients who to continue transfusion versus this therapy. You can see in the figure D that the fetal hemoglobin percentage in these patients was much higher. The sickle hemoglobin percentage in figure C is much higher. But they had this protocol for basically giving high dose hydroxycarbamide and found that no child had a positive adjudication for their stroke whenever they, in this particular study of patients. And so some interesting findings there. The ASH guideline kind of comments on this and essentially says that in patients who have received transfusion for at least a year and they're interested in stopping, then they suggest using hydroxyurea at the maximum tolerated low dose. But as you can see, it's based on low certainty and it's a conditional recommendation. So more study is needed in this area. What we also know, and we haven't really talked about to this point, is the fact that there's also hemorrhagic stroke. There's this whole world of hemorrhagic stroke and other high-risk features like subarachnoid, IVH, aneurysmal changes, moya-moya changes that all lead to bleeding complications. And over time, in a very similar way to stroke, patients have a higher and higher risk of having hemorrhagic stroke over time as well. So what are the research gaps in this area? There's many, and there's some areas of conflict. When exactly is it safe to stop transfusion? What should be done whenever you see borderline findings? Somebody is just below 200, and then, when are you going to repeat that? So there are some guidelines out there on, doing increased frequency of screening, but it's not really standard protocol on exactly when, the number of weeks, the number of months, et cetera. And so this can be tricky and how to interpret that clinically, how to inform your patients and the parents. And so what do you do with low mean flow velocities? What do we do with vasculopathies and occlusions? So more study is needed on these kind of findings. And beyond targeting anemia and hemoglobin S percentage, what is the exact thing that slows the intimal disease process or vasculopathy progression? What are your other biological targets? We need to understand the interplay of this anemia, viscosity, perfusion, hydration, all of these combination of factors, and try to help target this in a multifaceted approach. And what are the other TCD biomarkers for stroke risk factors beyond large vessel vasculopathy? Are we able to pick up on things like perfusion and other issues, PI, et cetera? Do these help us in understanding our sickle cell patients more? And what are the other applications of neuroultrasound whenever you're having an acute stroke case or a sickle cell crisis? We typically don't recommend to do so because it's going to affect the velocities. But is there an application is the question. And can we use TCD in the weaning process, so to speak, of transfusion? What do we do with hemorrhagic stroke? So as you can see, a lot of questions. There are some clinical gaps, credentialing requirements at the moment, RPNI in the United States, and it's not necessarily pediatric or sickle cell TCD focused. We need more experienced centers practicing TCD for sickle cell populations. It's still not 100% in use in the population of sickle cell in our communities, and certainly not worldwide. And so we need a lot of people to get credentialed and start this process, and maybe we need more specific credentialing for people who are going to be more focused on pediatric TCD. The society guidelines we have, I mentioned the ASH guidelines. Prior to that was the National Heart, Lung, Brain Institute guidelines, and then also the practice standards for TCD, which we still use to this day. When they looked at how people are practicing sickle cell protocols in their local setting, what they found is that essentially, even though we have this standardized process of annual TCD screening, not everybody is doing it the same. And in terms of cerebral vessels that are incubated, there are differences. You can also take a look at this table in the recording later for more detail, but essentially what this is showing is that after you have a conditional TCD or abnormal TCD, people are doing different things, not immediately initiating transfusion, sometimes initiating hydroxyurea, sometimes doing follow-up imaging first. And so we really need a standardized protocol. And even in terms of how people are reporting these TCD findings in sickle cell patients, there's extreme, the word extreme, variability found in reporting and interpretation. So, it really kind of shows that we need more to be done in terms of helping address these clinical and educational gaps. And, these are some listed coursework that you can kind of refer to. Wake Forest is, how I got credentialed as an RPNI and a great coursework, as we know. But there's other offerings as well. And, American Society of Neuroimaging has multiple talks on pediatric TCD and sickle cell. So highly recommend these agencies. And in terms of competency, should there be more focused education for pediatric ultrasound and interpretation? And I believe that's my time.